name is Julia Grabs. I'm the editor-in-chief for JACC Case Reports. And today is great pleasure to have four worldwide known interventional cardiologists, and we will discuss on the webinar during the mini focus issue on complications, interventional complications. I would like to welcome Dr. Eric Bates, who is professor of cardiology at the University of Michigan, Dr. David Fishman, professor of medicine at the Sidney Kimmel Medical College of Thomas Jefferson University, Dr. Mladen Vidovic, professor of medicine at the University of Illinois at Chicago, and Dr. Joel Giblett, who is consultant interventional cardiologist at Royal Papworth Hospital in Cambridge in the United Kingdom. So thank you very much, all of you, for being here. And I will start with the first case that has the title Percutaneous Closure of an iatrogenic inlet ventricular septal defect in atrioventricular canal. And the first author is Dr. Jose Castro Rodriguez, and the last author, Dr. Mariel Morrisens, and the authors are from CHU Bregman Hospital in Brussels in Belgium. So starting from this case, a 45-year-old woman, she had a partial atrioventricular septal defect with primum ASD and mitral cleft, and she presented with subacute shortness of breath at the outpatient clinic 2 months after she had the mitral St. Jude prosthesis implanted. From the clinical examination, she had a rough parasternal murmur. And the patient had the first surgery at the age of 27 years old. She had closure of the ASD and suture of the mitral cleft, and followed 5 years later by second surgery for a new mitral plasty and tricuspid annuloplasty. 6 years later, she had a pacemaker implantation. She had complete block, atrioventricular block, and she developed recurrence of mitral regurgitation. Therefore, she had the mitral replacement with St. Jude prosthesis, and the postoperative period was quite difficult with pneumonia and atrial fibrillation. So here the echocardiography demonstrates the presence of an interventricular shunt located beside the annulus of a mechanical mitral valve, and the heart catheterization confirmed the shunt. So they decided to discuss the case at the MDT, and they decide percutaneous closure, even though there is a lack of data on this type of VSD. So here is the whole procedure. I don't want to take long describing how they crossed the VSD, and they did retrograde approach, and then they used the catheter in order to try to close the VSD. And here is the 30mm multi-snare wire that used to capture the first retrograde guide wire in the pulmonary artery. And then it went to the right femoral vein, and they did an arterial venous loop, and they used the 6 French catheter in order the catheter could not pass the VSD because of a difficult path and through the tricuspid, and the authors decided to use the retrograde approach, repositioning the AR catheter into the venous part. And then what had happened is when they introduced the catheter through the left femoral artery and was used for the angiography of the VSD, they were able to perform an exact measurement. And the VSD, they mentioned that was 4 millimeters in width and 3 millimeters in length, and the delivery sheath was driven on the looping guide into the RV until contact was made with the catheter, and the authors chose a St. Jude Amblinger occluder. So it is rather complicated. Here they do a ventriculography, and the TE also confirmed the occlusion of the stent and the absence of any interference with the device. I must admit that it's quite complicated, at least for me, that I'm an imager. So I would be grateful if I could have your comments.
Well, I think from the point of view of the complication session that we're doing, obviously this is a complication related to the cardiac surgery, and we're not in a position here to comment on whether or not anything could have been done differently. but these cases with these AVSDs are notorious for having lots of sort of recurrent need for surgery, recurrent breakdown, residual shunts and problems. And actually what we've got here is a tour de force in terms of a structural case. It's a beautiful demonstration of creating that AV loop on that video, which was very good to see. And they've used the Amplaps duct occluder, which is an off-label use of that particular device, but they've looked at it, they've measured it, and they've found a device that fits, which is essentially all that you can do in these cases. Each one is going to be unique, and they've got a very nice result here at the end.
This just demonstrates the patience you have to do this type of work. I mean, this was a long, complicated case, I'm sure, in terms of the time frame, but they, got done what they needed to get done, and they should be congratulated on that.
And I was just saying, like, you mentioned it was off-label use of Amplats. It just shows you that we clearly are, there's great potential for technological advancement in closure devices, because people have been adapting Amplats for a variety of closure purposes, but I think that there's both need and opportunity to develop a next generation device. I think
there are lots of devices available, and it's difficult to bring to market. Certainly in Europe, we have more devices available for this. We have Oclatech devices and some Gore devices that are only available in that market, and the difficulty is that these devices are used in small numbers of patients, and there needs to be perhaps better pathways to allow companies to develop these.
Excellent point.
Thank you very much. So I will move to the next case, which has to do with the Impeller device and the intraventricular free-floating thrombus in an Impeller-supported patient. Damage control in a no-win scenario. The first author is Dr. Dan Nguyen, and the last author, Dr. Richard Cheng, and the authors are coming from the University of Washington Medical Center. And here, just to describe again, we have a 58-year-old man, progressive heart failure from coronary artery disease, and he's been admitted with cardiogenic shock in the setting of STEMI. Of non-STEMI. And then the transthoracic echo demonstrates severely dilated LV, ejection fraction 10%, and I will show you how they did contrast, and they demonstrate that there was no mural thrombus. Then a transfemoral Impeller device was implanted without complication as a bridge to LVAD, and the patient was well anticoagulated with systemic heparin, and they monitored his anticoagulation quite tightly. This is the echo, that is the transthoracic echo. We can see forapical chamber view, extensive akinesis of the ventricle, almost nothing is moving. We can see that some segments are scarred, and maybe the lateral wall is more viable. However, the ejection fraction is 10%. And then, of course, they are doing the definitive, the contrast, in order to identify that there is no mural thrombus. This is all trabeculation. But the ejection, even the contrast enhances the calculation of ejection fraction, and we can see that the ejection fraction is extremely poor. However, on hospital day 6, and this is quite impressive, the Impeller started developing incessant suction events. And you can see that the patient has extensive clots into the ventricle, into the left atrium, and also into the left ventricle from 4 centimeters up to 1.5 centimeters. It's quite shocking to see such a picture, because you know that this sooner or later may embolize actually. Unfortunately, the patient developed dysarthria as was, I won't say expected, but that was the main danger here, and was found to have a stroke on the CT imaging. And during this time, the Impeller continued to suction without providing any significant hemodynamic support. The decision was made to remove the Impeller and place a balloon pump while actually using the protection for the Sentinel for the stroke protection. And then leaving the Impeller, transversing the aortic valve, offered the benefit, as the authors mentioned, to provide temporary LVOT obstruction to prevent the thrombus from embolizing. This is very important. I would like your comments here on the Impeller, how they chose then to use the balloon pump, and most important, what maybe we should look for when we deal with patients like this patient.
So this is a very interesting case, obviously because we're discussing Impeller, and there's a lot of controversial, it's a controversial area, particularly using it as a bridge to one more permanent LVAD device. I think the first thing is, looking at those images of the echo and seeing that thrombus, it's concerning. I mean, I wouldn't want to be the doctor at the bedside seeing that, and then how to deal with it. But these devices come with risks such as thrombotic events, strokes, and on the other hand, come with bleeding. And so I think, we still are in the infancy of these devices. We still need to know a lot more where they should probably be best used. In this particular case, the patient had the device in for 6 days. The longer they're in, the higher the risk of a thrombotic event such as this occurred. So, my question is, how long did they plan to leave that device in should there not been a stroke? In this case, not surprising that something would happen like that. The other thing is, we still don't know what the right anticoagulation is. The company recommends the use of heparin with an ACT of 160 to 180. In this case, they were using the anti-10A factor levels. There too, we don't have enough data. They use their hospital protocol. So we don't know what's the best protocol in terms of how to anticoagulate these patients to prevent clot, and on the other hand, prevent bleeding on on both sides. So I think this case highlights some of the concerns we have with these devices.
And I think the point that I see in this case is, I'll just give you a little anecdote. I was on the wards last week attending on the rounds, and there's a patient who has 2 free-floating thrombi in the left ventricle. So the consulting physician asked me, well, can't you just angiovac them out real quick and take care of them? And I said, well, that's not so simple, because angiovac on the left side is a little hairy, and this case shows this, right? They tried to get rid of the thrombi. They put the Sentinel device, which was really approved and developed for TAVR embolic protection, but it's not even close here. They tried to protect the brain, but again, that's not so easy. So I think there's a lot to be learned, and I think we're not even close how to address left-sided free-floating thrombi. I mean, they could be in the ventricle, on the valves, aorta, again, because embolization is clear and present danger, as you see here, and it's not a trivial issue.
So I guess the question I'll ask you is, how do we prevent it? I mean, do you have any, what are you doing to prevent this? Because treating it is going to be difficult, as you pointed out, but, are there better ways to preventing these things from happening?
Yeah, better
happening frequently.
Monitoring different drug, meaning you name it. Would bivalirudin would have been better? Would low unfractionated heparin been better? Would have been the low molecular weight heparin? As you said, we don't know, especially for prolonged periods of time.
Joel, what are they using in England in terms of anticoagulation for these or monitoring these patients?
Well, I have to say that Impeller use in the United Kingdom is nowhere near as high as I think if this had been in Papworth, this patient would have been on ECMO as opposed to an Impeller device. But that comes with its own complications just as much. That's not to say that the one is going to be better than the other. I think we would probably, when we have patients on, we would have unfractionated heparin infusion running with an Impeller if it was being left in. But I don't know that anyone knows what to do. That's, as you said, that's the problem.
And just to play the devil's advocate, it's tough to blame Impeller for a clot with somebody with an EF of 10%. And
absolutely.
Massive wall motion never met. It's really tough to blame it to one or the other.
I think an important point is not to place a mechanical support device without having a clear idea of what the next step in treatment is. If this was just to put in and watch and monitor, the longer the dwell time, the higher the complication rate. On the other hand, if they have a target of trying to get the pulmonary vascular resistance down, and they have a surgeon who's willing to go to the operating room as soon as possible, the shorter the dwell time, the fewer the complications.
Absolutely. And once they've had this stroke, they've obviously done they've done their best to get that thrombus out and protect the brain, but I think the patient's in a very bad situation at that point. I don't know which surgeon is going to want to take the patient to the OR with a recent stroke. They're probably going to have a hemorrhagic transformation at that point in the OR.
Perfect. Thank you very much, all of you. I will move to the next case that has the title axillary artery pseudoaneurysm following percutaneous transaxillary access for Impeller device placement during percutaneous coronary intervention. And the first author is Dr. Anna Salharbi, and the last author, Dr. Jason Moreland, and the authors are from West Virginia in Morgantown. So here, again, a summary of the case, 61-year-old female. She had a prior history of coronary artery disease requiring bypass surgery, and she's coming with retrosternal chest pain radiating to the left arm and associated with shortness of breath. She has this normotensive, heart rate is 75, and given her presentation and the past medical history, she underwent coronary angiogram that revealed occlusion of the graft vessels and severe multi-vessel native disease, including a severe lesion in the left main coronary artery. So then the authors decided to do high-risk PCI with mechanical circulatory support using an Impeller device, and they performed transaxillary approach. And this is because her common femoral arteries were known to be small in caliber and diffusely diseased. So then following the procedure, of course, the patient developed a medium-sized hematoma, the insertion site, and she dropped her hemoglobin, and the hemoglobin dropped, but remained stable. She was discharged 3 days later, and she was evaluated in the clinic. The pain improved at the hematoma site, and there was no obvious size increase. However, 1 week later, she presents again to the emergency department with worsening right upper extremity pain and a significant mass at the axillary access site. And there is active extravasation of contrast into a pseudoaneurysm of the right axillary artery. This is the main complication, which is beautifully imaged from the CT angiography. And the authors then performed a stenting of the right axillary artery, and this is how they fix the patient actually, and they resolve the pseudoaneurysm. So here I would like your comments again about access and especially from the Impeller.
I mean, alternative access femoral are all the rage. Not that long ago that there was this transapical access for TAVR, and then people noticed that that's such not a great idea. So then there was a search for an alternative site if the femoral artery is hostile, as we saw in one of the previous cases, which could be calcifying and ruptured. So axillary access is clearly in vogue right now for alternative access sites. And again, we'll clearly see more of this. So I think it's I think this is a case report, but I could easily see us learning more how to prevent, avoid, and anticipate this from happening.
Mm-hmm. Thank you, Mladen. Any further comments, or have you performed transaxillary access?
So our partner at who does structural does actually quite a bit of them, and he does TAVR with them, and he does Impeller for them. And I have to say he's very successful with that, and it's a great bailout for quite a bit of patients with PURE-F who need complex PCI or TAVR, and I think it works really, really well. Patient mobility is excellent because they can ambulate very quickly, so it's a very attractive option.
We're seeing more and more the use of the axillary artery for patients being considered for transplant. Given the current system to allocate the hearts, most of them have to be on some kind of support device. So more and more, although the balloon is a small device, a lot of balloons are going in the axillary artery to support patients as they're listed for transplant. The problem is that device, the balloon, is not approved for the axillary artery, and They're frequently having to be changed because they just they malfunction. But I think for a number of reasons, we're going to be seeing a lot more of this approach, whether it be for TAVRs or transplants or just for support during a complex PCI.
I wonder,
Yeah.
when we're working patients up for a TAVR, we normally have spend a lot of time looking at their CT, planning, understanding exactly where we want to puncture the artery. And I wonder whether in some cases where the axillary artery is being used for complex coronary work, whether that is not being done. It's and I don't know in this case whether they had a CT in advance to think about it, to look to see where there was calcification in that vessel, whether that vessel looked unattractive on that basis.
Perfect.
My suspicion, most of it's being done by ultrasound visualization, and not really, although they do have CTs of the chest, so they should be able to look at that. But I think a lot of this is ultrasound driven.
And I think that's what I think. I spend a lot of time getting ultrasound guided access for TAVR in the groin, but I've normally spent a good period of time looking at that artery on CT first before we started.
Thank you so much. That's a very useful and very interesting discussion. And I will move to the last case that has the title, A Mechanism for Stroke Complicating Coronary Thrombus Aspiration. And the first author is Dr. Tanawan Riangwat, and the last author, Dr. James Blankenship. And the authors are from Geisinger Medical Center in Belleville from United States. And just to briefly present this case, a 54-year-old female patient, she presented with retrosternal chest pain and ECG demonstrated inferior STEMI. From her background, she was hypertensive, diabetic, and she had obstructive sleep apnea. And 3 hours after the initiation of symptoms, she had a dominant right coronary artery with 100% proximal occlusion, as you can see here on the angiogram. And the authors, when they pass the export XT catheter, they demonstrate that the artery had several large thrombi. On the third pass of the catheter, there was a blood return through the catheter and was stopped prematurely, and the aspiration catheter was withdrawn with constant suction, and making sure that the guide catheter was deeply engaged in the ostium of the right coronary artery, and then a thrombus was visible protruding from the aspiration port of the guide catheter. And then the authors described they saw that there was residual thrombus here on the proximal artery, and now at the PDA, posterior descending branch, also was occluded by thrombus. And they used aspiration catheter, which was removed from the without visible thrombus, and the connector was flushed. And the authors then opened the bleed back control seal by pressing down the cap, and they described practically how they managed to get out a large linear thrombus that adhered to the guide wire. So then the target lesion was stented with a 3.5 to 30 millimeters drug-eluting stent, and the final result is excellent. I will show you here of the RCA that you can see there is no residual thrombus and normal distal flow. And they started the patient on eptifibatide, and it was continued for 18 hours. So here I just mentioned practically the primary PCI with or without manual thrombectomy, which I thought that's a very important paper, the total investigators. It's also been quoted by the authors here. What are your comments on this case?
I'd say as our interventional neuroradiologist, is this whole family of devices, clot retrievers, right? Which is like a little kind of basket of wires. And they have shown very good results in the brain by taking clots out. And our suction catheters, like the ones used in total trial, were not really so successful. That's what a total trial somehow put an end to. dominance of these devices. If you look at this wire full of clot, it almost looks like a primitive clot retriever, right? It's just that's what they ended up doing. So yeah, this does happen when you have an aggressive clot. You have to be really, really careful.
So I think we should clarify that this isn't mechanical aspiration. This is aspiration thrombectomy. And this is a simple case compared to the previous three, but there's some very important teaching points. That there is a slight signal that there might be some causing stroke when you do this on a selective basis, since we're not supposed to do it on a routine basis. These right coronaries sometimes have a lot of thrombus, and the teaching points are: number one, make sure the guide catheter is deeply seated in the artery. Number two, have negative aspiration pressure when you pull the aspiration catheter back into the guide catheter. And then the nice thing about this case is they found out that the clot that couldn't aspirate was stuck at the connection of the guide catheter and the TUI. So the point is, to avoid the risk of stroke that might be associated with procedure, disconnect the TUI from the guide catheter, let it back bleed, and flush the TUI to make sure there's no hidden clot inside the TUI, as there was in this case.
I think this was interesting. I actually wondered, given the amount of thrombus that came out at that point, whether I might have actually just taken the whole catheter and wire out of the system as one, because even if you've pulled this long segment that they've pulled out, you don't know whether there's another little residual bit sort of sat in your catheter somewhere, whether a piece is broken off. I think I've moved to a situation where I hardly ever am doing thrombus aspiration in this fashion, and I wonder whether an alternative to thrombus aspiration here would have been balloon angioplasty, glycoprotein 2B3A inhibitors, and returning the patient to the lab in 24 hours time, providing that they were stable for stenting at that stage, rather than trying to deal with such a big thrombus burden. It's hard to know for sure.
And there was this unfortunate drug, fondaparinux, which was associated with catheter thrombosis. We essentially put an end to that drug used in PCI. Catheter thrombosis is really rare. I mean, it's not a common phenomenon with contemporary anticoagulation with ACT monitoring, but it sure can happen. And I agree with you. I would have probably taken the whole system out.
Perfect. Any further comments on this case, or in general, maybe?
These have been some great cases, which I think a lot of learning points for everybody listening.
Thank you very much, all of you, for your contribution. I don't know, Eric, do you have any further comments, Mladen or Joel?
Well, I used to joke the last several years that it's hard to teach trainees complications because routine angioplasty goes so easily, and you don't have enough complications in your training time to be ready to do all these really fancy responses to complications. So the case report format showing complications and how experts problem solve, great for learning. It's the interventional cardiology isn't a technical sport, it's a cognitive sport. And the problem solving here in these cases was excellent.
I agree. And I think it's for us to sit here at this point and calmly think about the problems in some of these cases. It's a much more heated situation, and they've done very well.
It's always nice to have the benefit of tincture of time, right? In retrospect, and when you're in the heat of the battle, absolutely.
Yeah.
You know, as a person doing interventional work for a while, I still perspire looking at these cases.
That's perfect. Thank you so much, all of you, also for handling most of the cases. And I will also remind the audience to subscribe to JACC Specialty Journals podcast. And thank you very much for your participation.